Welcome to Part 2 of Resuscitation Concepts. This podcast should be viewed after listening to and watching the first one, and after some preparation by reading the assigned texts. Again, the primary reference is Chapter 55 in Morgan and Mikhail's Clinical Anesthesiology, 5th edition. The objectives of this podcast are to review the pharmacology, to review electrical therapy, and to review cardiocerebral resuscitation and the use of hypothermia. The use of pharmacology implies the access to the intravenous route. Guidelines recommend that all medications be flushed into the circulation with 20 ml of saline, and also recommend that the upper extremity is the preferred location. Central venous access can be considered when peripheral venous access appears to be inadequate. In the absence of an intravenous, the following medications can be given via the endotracheal tube: lidocaine, epinephrine, naloxone, vasopressin, and atropine. The guidelines on the one hand recommend that they be diluted with 10 ml of saline and administered, quotes, via a catheter which extends beyond the tip of the tracheal tube, or, according to another source, deep within the bronchial tree. In the case of difficult venous access, guidelines recommend that intraosseous administration be considered, with the recognition that it may require an increased dose and that this route is best for children, although it has been used for adults. Continuing with pharmacology, sodium bicarbonate, 1 milliequivalent per kilogram IV, is permissible for a pre-existing metabolic acidosis, for the treatment of hyperkalemia, and also for tricyclic antidepressant or barbiturate overdose. Although it is an effective alkalinizing agent outside the cell, sodium bicarbonate will increase intramyocardial acidosis and may reduce the possibility of cardiac resuscitation. For what it's worth, anecdotally, many practitioners have observed a significant and noticeable improvement in cardiac function when sodium bicarbonate is administered. Nonetheless, it is not a first-tier drug any longer. Another old standard is atropine. Atropine is indicated for symptomatic bradycardia and heart block, but not for asystole or pulseless electrical activity. The dosage in adults is 0.5 to 1 milligram IV per dose to a maximum of 3 milligrams. And in pediatrics, 0.2 milligrams per kilogram to a maximum of 1 milligram in adolescents, with a minimum dose of 0.1 milligrams in any case. The next few slides are reproductions of a table for specific drugs. The first one is epinephrine. As you're all probably quite aware, the alpha adrenergic effects are the desired effects of epinephrine. The indications are severe hypotension, electromechanical dissociation, ventricular asystole, severe bradycardia. The dose is 1 milligram IV and titrated by infusion. This table uses a standard concentration of 1 milligram in 250 mils, which is not what is the standard concentration at the University of Kentucky. However, it is worthwhile being aware of the dose of epinephrine when administered by counting drops or micro drops. A second vasoconstrictor is now recommended, and vasopressin is recommended in a single one-time dose of 40 units in order to increase vascular tone. Amiodarone is classified as a complex antiarrhythmic with effects on sodium, potassium, and calcium channels, as well as alpha and beta adrenergic blocking properties. Its indications are SVT and polymorphic VT and wide complex tachycardia of uncertain origin, etc., 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 as outlined in this table. The dose is 150 milligrams over 10 minutes, followed by 1 milligram per minute for 6 hours, then 0.5 milligrams per minute. However, in the case of pulseless VT or VF, the initial dose is 300 milligrams diluted in 20 to 30 mils of saline or dextrose. Some references recommend dextrose only for dilution and also recommend the use of an inline filter, such as found in the top drawer of your drug tray. It can be given via the intraosseous route, and the most common side effects are hypotension and bradycardia. The use of magnesium is recommended with known hypomagnesemia or with torsade de pointe and prolonged QT interval with normal serum levels of magnesium. The recommended method of administration is 1 to 2 grams diluted in 50 to 100 mils of dextrose and water, administered over 15 minutes. It can be given intraosseously. It is not a routine medication. In addition to epinephrine, dobutamine is included in the table of recommended medications in the treatment of cardiac arrest, and you should know that dobutamine is a synthetic catecholamine with potent inotropic effects. It is in fact a racemic mixture of alpha and a racemic mixture of DNL dobutamine with alpha and beta effects. The essential effect of dobutamine is that it is a beta agonist and is typically administered in dosages of 5 to 20 mics per kilo per minute and is titrated to clinical endpoints. Another antiarrhythmic included in the table in your reference is diltiazem, which is a calcium channel blocker, and it has the potential to terminate re-entry arrhythmias and to control the ventricular response in atrial fibrillation, flutter, and multifocal tachycardia. Typically, a loading dose of 0.25 milligrams per kilogram is administered, and an infusion of 5 to 15 milligrams per hour can be used. Although it can exacerbate ventricular dysfunction by impairing myocardial contractility, it is less potent than verapamil in this regard. The use of calcium as a resuscitative agent has fallen into disrepute, and it is conspicuously absent from the table, along with sodium bicarbonate and beryllium. The indicated use of calcium includes hypocalcemia, hypermagnesemia, and calcium channel blocker overdose. A typical dose is 2 to 4 milligrams per kilogram, such that would calculate out to 150 to 300 milligrams per dose. And since calcium chloride usually comes in a 10% solution, which is 100 milligrams per mil, that means that the pre-filled syringe would typically be good for about 3 doses. Moving on to electrical therapy, we'll first discuss transcutaneous pacing, which is indicated for bradycardia and high-grade AV block. The guidelines recommend placing the negative electrode at the V2 position and the positive electrode at the left posterior chest lateral to the spine. In this algorithm, it is apparent that if there are serious signs or symptoms due to bradycardia, an intervention sequence of atropine, transcutaneous pacing if available, the use of positive inotropic agents, positive chronotropic agents such as dopamine or epinephrine are indicated. As I alluded to earlier, and as this slide summarizes, if epinephrine is prepared as 1 milligram in 250 mils of diluent, this gives you a concentration of 4 micrograms per mil. A rate of 30 mils per hour is 2 mics per minute. A drip count of 1 microdrop per second is equivalent to 60 mils per hour, or 40 micrograms per minute. Therefore, even if you don't have a pump with advanced function, you can deliver the dose of epinephrine, at least, in a fairly accurate fashion. This table summarizes the energy requirements for cardioversion using biphasic wave morphology. Some of this is dependent on the manufacturer's recommendations for dose of energy. However, the essence of this slide is to show that the energy dose for atrial flutter is somewhat less than for atrial fibrillation, and that the standard dose of energy to terminate ventricular tachycardia or ventricular fibrillation is in the 120 to 200 joule range. This slide provides a lot of information and is perhaps a little bit overly complex. However, if you take the time to review it in detail, there's much to be learned from it. The essential bit of information regarding adenosine appears to be the fact that it should be considered only if the dysrhythmia is regular. The guidelines do allow for consultation in complex cases, or if there's uncertainty as to the best drug therapy. It is of interest that this table does include procainamide, a very old drug for the treatment of of stable wide QRS tachycardia. Moving on from pharmacology and electrical therapy, the next topic in this podcast is cardiocerebral resuscitation and hypothermia. Cardiocerebral resuscitation is a term which I found defined in the textbook The Heart by Hurst in chapter 50. And I found that it originated at the University of Arizona, and in keeping with modern guidelines is based on maintaining circulation, not ventilation. In addition, the concept recognizes 3 phases of ventricular fibrillation, which are termed electrical, circulatory, and metabolic. This algorithm, which is taken from the textbook, depicts the approach which is called cardiocerebral resuscitation, and which emphasizes closed chest compressions and minimizes ventilation until perhaps a advanced airway is available. This very interesting excerpt from the textbook, The Heart, shows cardiac MRI images in a swine model. And the essential information here is that the right ventricle dilates almost immediately with ventricular fibrillation. After a period of time, the left ventricle becomes unresponsive, and irreversible damage has occurred and is referred to as stone heart. The 3 phases of ventricular fibrillation, as I alluded to, are called electrical, and at this time, at the very early phase, there is enough myocardial ATP present that defibrillation alone can restore a perfusing rhythm. Shortly thereafter, the ventricle enters into what's called the circulatory phase of ventricular fibrillation, at which time there's depletion of myocardial energy substrates and the development of acidosis. Coarse VF becomes fine VF, and it has been shown that defibrillation without closed chest compressions is unlikely to be successful during this phase. The third and terminal phase of ventricular fibrillation is called the metabolic phase. At which time there are diminishing odds of successful defibrillation and intact neurological survival. It is felt that mild therapeutic hypothermia may delay the onset of this phase. Very few patients survive after more than 15 minutes of untreated or inadequately treated cardiac arrest. Some of the original publications regarding cardiocerebral resuscitation have concluded that almost anything is superior to bag valve mask ventilation, partly because of the ineffectual nature of bag valve masks by unskilled people, but also due to the fact that it is not an easy technique to be successful at, even in skilled hands. Consistent use of closed chest compressions rather than attention to ventilation is currently the standard. With respect to gasping respirations or agonal respirations, these are found to be quite common after the onset of cardiac arrest, and is an indication that brainstem neurons are still firing. Its presence is actually correlated with survival. Unfortunately, about 20% of patients who gasp are thought to be not in cardiac arrest and end up not receiving chest compressions, at least in the as written in Hurst, the Heart. It is fairly well accepted that hypothermia is neuroprotective and is felt to improve short-term neurologic recovery and survival. This is the title page from a publication in Anesthesia and Analgesia 1959. So it's pretty apparent that hypothermia has been recognized as beneficial for quite a long time. The Hypothermia After Cardiac Arrest Study Group publication in the New England Journal in 2002 concluded that hypothermia conferred a survival benefit. And a second publication in the same issue from Australia also concluded that induced hypothermia improves outcomes in patients who are comatose after resuscitation from out-of-hospital cardiac arrest. There is even a Cochrane review published in 2012 supporting the use of hypothermia for neuroprotection in adults after cardiopulmonary resuscitation. So while hypothermia is recommended, all answers are not yet available, and more recent studies have questioned the benefit of targeting a body temperature of 33 degrees, for example, in the treatment of cardiac arrest. I mention this not to dissuade you from using hypothermia, but only to bring to your attention that the thinking is that hypothermia may not be the explanation or the treatment that improves outcome. It could possibly be prevention of hyperthermia or some other yet unknown explanation. Well, essentially this concludes the second podcast, and I encourage you to review the quiz questions that come with these two podcasts, and to read the references that have been suggested to you in order to master this subject. Thank you.